Dr. Srismitha, Professor of Pathology. I have over 10 years of teaching experience, both undergraduates and postgraduates. I have around 11 international publications to my credit, and I have 2 research projects which are ongoing. I'm here to take you on the topic with an overview of red cell disorders and bleeding disorders. So I'm going to give you a brief overview of these topics today. So today's learning objectives are understanding the general features of anemia and classify anemias, describe the major causes of anemias, and review some common hereditary and acquired hemolytic anemias. We will also discuss the causes of bleeding disorders as well as classify them and describe the major types of bleeding disorders. Now moving on to the general features of anemia. Anemia is defined as the decrease in hemoglobin as well as the oxygen carrying capacity of blood specific for that particular age and sex of the patient. So clinically, anemia can present as pallor, as tiredness, dyspnea on exertion, or glossitis in some patients. In severe cases of anemia, the patients may present with koilonychia, which is nothing but spooning of the nails, as well as pedal edema, which is a dependent edema in the legs. In case of hemolytic anemia, the patient can present with jaundice and gallstones, which are the pigment gallstones, and also leg ulcers due to vaso-occlusion. The patients may also present with splenomegaly in case of hemolytic anemia. Now we move on to the classification of anemia. Anemia is based on the morphology classified as microcytic anemias, normocytic anemias, and macrocytic anemias. So when the mean corpuscular volume is between 80 to 100 femtoliters, we call it as normocytic anemia. So the red cell is normal in size, so we call it as normocytic anemia. So the most common normocytic anemias are anemias that occur due to blood loss, hemolytic anemias, aplastic anemias, and anemias of chronic renal failure. When we go to microcytic anemias, the MCV value is less than 80 femtoliters. So when it is less than 80 femtoliters, the red cells are much smaller in size and they present as microcytes. So this is common in iron deficiency anemia, in thalassemia, sideroblastic anemia, and anemia of chronic disease. Macrocytic anemias, on the contrary, are anemias where the red cell size is large. In other words, the mean corpuscular volume or the MCV is more than 100 femtoliters. The prototype for macrocytic anemia is megaloblastic anemia. Macrocytes are also seen in liver disease, alcoholism, as well as myelodysplastic syndromes. We can also classify anemias based on the severity as mild, moderate, and severe anemia. When we say mild anemia, it is the hemoglobin level from the lower limit of normal up to 10 grams per deciliter is called mild anemia. Moderate anemia is hemoglobin levels between 10 to 7 grams per deciliter, and severe anemia is anything less than 7 grams per deciliter. Further, we can classify anemias based on the etiology. The 2 main categories are anemias due to impaired red cell production and anemias due to excessive red cell destruction. In other words, they are called hemolytic anemias. So when you come to impaired red cell production, there is an impairment in the red cell production because of which the patient develops decreased oxygen carrying capacity. The most often this is because of iron deficiency anemia or other nutritional deficiencies like B12 or folic acid deficiency, which leads to impaired red cell production. And the other causes of anemia due to impaired red cell production are anemia of chronic disease, sideroblastic anemia, aplastic anemia, anemias of liver disease and endocrine disorders, myelothysic anemias, and congenital dyserythropoietic anemia. Hemolytic anemias are further classified as defect which is intrinsic to the red cell and defect which is extrinsic to the red cell. So, if it is intrinsic to the red cell, it can be either a red cell membrane defect, a defect in the hemoglobin quality or the quantity, or enzyme defects. So, the red cell membrane defects are further classified as hereditary spherocytosis and hereditary elliptocytosis. Defects in hemoglobin can be either quantitative or qualitative. Quantitative disorders are thalassemias. Qualitative disorders can be sickle cell anemia, HbS disease, HbD disease, HbE and HbC defects. Enzyme defects include glucose 6-phosphate dehydrogenase deficiency and pyruvate kinase deficiency. When we say the extrinsic abnormality, it is immune hemolytic anemias. Immune hemolytic anemias are autoimmune, alloimmune and drug induced. Autoimmune hemolytic anemias are nothing but the antibodies are developed against self antigens, and drug induced, certain types of drugs can produce antibodies against the self antigens, and it can lead to hemolytic anemia. We further have mechanical hemolytic anemias, the most common of which is microangiopathic hemolytic anemia, which is a common complication of disseminated intravascular coagulation. Some patients with cardiac prosthetic valves can develop cardiac hemoglobinuria, and soldiers can develop March hemoglobinuria. There are also direct action of physical agents, chemical agents or infectious agents which can cause hemolysis, and hypersplenism is also a cause of hemolytic anemia. Next, we further move on to discuss each of these anemias and their salient points. The first is the iron deficiency anemia, which is the most common anemia that we come across in practice. So, etiologically it is caused due to chronic blood loss, insufficient dietary iron or malabsorption of iron. These patients generally present with fatigue, pallor, pica and glossitis. So, morphologically in the peripheral blood, what we see are microcytes and also hypochromic cells. Certain cells are ring cells, and we can also see elongated cells like teardrop cells and pencil cells due to the low hemoglobin. There is marked anisopoikilocytosis in the peripheral blood. The bone marrow shows erythroid hyperplasia and micronormoblastic maturation, and on Pearl's stain we can see that there is absent iron stores in the bone marrow. The diagnosis is generally based on a complete hemogram, and also we can do iron studies where there is low serum ferritin levels, decreased transferrin saturation as well as increased TIBC, and we also confirm it with the peripheral findings. Moving on to megaloblastic anemia, this is the second most common cause of nutritional deficiency. It is caused due to vitamin B12 or folic acid deficiency. This leads to impaired DNA synthesis, and that causes ineffective erythropoiesis in the bone marrow, producing megaloblasts. And it can also occur due to malabsorption, and usage of certain drugs like methotrexate can also cause a deficiency of B12 and folic acid, causing megaloblastic anemia. A special type of megaloblastic anemia is pernicious anemia, where it is due to defect in intrinsic factor. Clinically, these patients will present with the same symptoms of anemia as pallor and lassitude and tiredness, but in addition to that, they also have neurologic symptoms like glove and stocking deformity, as well as tingling and numbness in the peripheral nerves. The peripheral blood smear shows macrocytic red cells and hypersegmented neutrophils. In addition to that, the smear can also show Howell-Jolly bodies and Cabot rings. Bone marrow is characterized by erythroid hyperplasia, and there is ineffective erythropoiesis with large abnormal megaloblasts with a characteristic sieve-like chromatin. This is the characteristic feature that is appreciated in the bone marrow. In addition to that, we can also see giant metamyelocytes and giant stab forms in the bone marrow. The diagnosis is based on measuring serum B12 and folic acid levels, and elevated methyl malanoic acid is also seen in B12 deficiency. Moving on to hemolytic anemias, thalassemia is one of the inherited disorders of hemolysis, where there is alpha or beta globin chain defects that causes severe anemia and systemic manifestations. So, because of inherited mutations, there is reduced or absent alpha or globin chains synthesis, which disrupts the hemoglobin balance. So, these patients are based on the clinical severity, they are classified as thalassemia major, thalassemia intermedia and thalassemia minor. Thalassemia major presents in early childhood with severe anemia, hepatosplenomegaly and characteristic skeletal deformities like mongoloid facies as well as crew cut appearance on X-rays. Thalassemia minor is a very mild form of thalassemia where the symptoms are quite similar to iron deficiency anemia. The peripheral blood picture also resembles iron deficiency anemia, and we need to go for iron studies as well as hemoglobin electrophoresis to rule out thalassemia minor. Thalassemia intermedia presents with features which are intermediate between major and minor thalassemia. Morphologically, in case of thalassemia, the peripheral blood shows microcytic hypochromic cells. In addition to that, we can see a large number of target cells and nucleated RBCs due to ineffective erythropoiesis. In the bone marrow, we can appreciate erythroid hyperplasia, micronormoblastic maturation and increased bone marrow iron stores. This is in contrast to iron deficiency anemia, which will show absent iron stores. So, we can confirm the diagnosis by hemoglobin electrophoresis, which reveals abnormal hemoglobin fractions and genetic testing for globin gene mutations. Moving on to hereditary spherocytosis. Hereditary spherocytosis is a genetic red cell membrane protein defect which results in spherical erythrocytes which are prone to hemolysis. So, the genetic defect is in the red cell membrane proteins, namely spectrin and ankyrin, which reduce the surface area of the red cell, forming spherical and less deformable erythrocytes. So, these erythrocytes, when they pass through the splenic sinusoids, they undergo splenic sequestration and destruction, and this causes chronic hemolysis in these patients. Clinically, these patients will present with chronic jaundice, splenomegaly and anemia. In addition, the peripheral blood shows reticulocytosis. We can also see a number of spherocytes as well as microspherocytes in the peripheral blood. This can be confirmed with osmotic fragility test, which shows increased osmotic fragility. Sickle cell anemia is another genetic disorder where there is sickling, hemolytic damage and multi-organ complications. The genetic cause is the beta globin gene produces hemoglobin S instead of hemoglobin A. So, because of an alteration at the genetic level, the hemoglobin is transformed to hemoglobin S, and that will lead to sickling of these red cells in deoxygenated states. So, when the erythrocytes go through deoxygenation, these cells undergo a shape transformation and they form sickled RBCs. These sickled RBCs will return back to normal morphology upon oxygenation. So, repeated cycles of oxygenation and deoxygenation causes these cells to become irreversibly sickled, leading to microvascular occlusion. At the same time, these irreversibly sickled cells will undergo splenic sequestration and will cause severe hemolysis in these patients. So, these patients will have alternating cycles of sickling and desickling that is happening. On the peripheral blood, we can see that there are a number of sickled RBCs, and also you can see disformed erythrocytes, reticulocytosis as well. And because of the splenic sequestration, the spleens undergo autosplenectomy due to microvascular occlusion. And the laboratory diagnosis can be confirmed by hemoglobin electrophoresis, which can confirm the presence of hemoglobin S. Bone marrow shows marked erythroid hyperplasia with expansion of the bone marrow and extramedullary hematopoiesis. So next we move on to autoimmune hemolytic anemia. Autoimmune hemolytic anemia is an immune mediated destruction of RBCs. So these autoantibodies target and destroy the red blood cells causing hemolysis. It can further be classified as warm antibody type, cold agglutinin type and cold hemolysin type of immune hemolytic anemias. Clinically, these patients will present with symptoms of anemia, jaundice and splenomegaly, which are characteristic features of hemolytic anemia. The diagnosis is by a positive direct Coombs test, which confirms the autoimmune nature of the disease, and peripheral smear showing spirocytes. In addition, the peripheral smear also may show autoagglutination and or increased rouleau formation, which can confirm the diagnosis. With this, we come to an end of anemias. We will move on to bleeding disorders. We will classify the bleeding disorders and then we will discuss the salient points on von Willebrand disease and hemophilia. So, bleeding disorders based on the hemostasis, they can be classified as defects in primary hemostasis and defects in secondary hemostasis. So, primary hemostatic defects include platelet abnormalities, that is thrombocytopenia, which is a decrease in the number of platelets, and a qualitative dysfunction in platelets. Examples for those are Glanzmann's thrombasthenia as well as Bernard-Swallow syndrome. Von Willebrand disease is also a primary hemostatic defect where there is a deficiency of von Willebrand factor, and vessel wall defects such as vasculitis and scurvy also come under primary hemostatic defects. The typical bleeding pattern in case of primary hemostatic defects is mucocutaneous bleeding causing petechiae, purpura and epistaxis. Secondary hemostatic defects are most commonly involve coagulation factor deficiencies. So, hemophilia A, which is factor 8 deficiency, and hemophilia B, which is factor 9 deficiency, are the most common secondary hemostatic defects. In addition to that, patients can have acquired causes like vitamin K deficiency, liver disease and disseminated intravascular coagulation. This leads to deep bleeding including hemarthrosis and muscle hematomas. So, the inherited disorders of bleeding are von Willebrand's disease, hemophilia A or B and platelet function disorders like Glanzmann's thrombasthenia. Acquired causes include liver disease, vitamin K deficiency, disseminated intravascular coagulation, which can be distinguished by etiology and clinical context along with the laboratory parameters. Now, let us discuss about hemophilia. Hemophilia is basically of two types, that is hemophilia A and hemophilia B. Hemophilia A occurs because of factor 8 deficiency and it is an X-linked recessive disorder. Hemophilia B occurs because of factor 9 deficiency and this is also an X-linked recessive disorder. The severity of hemophilia can be classified by the factor activity. When the factor activity is less than 1%, we call it as severe hemophilia. When the factor activity is between 1 to 5%, we call it as moderate hemophilia, and if the factor activity is between 6 to 40%, it is classified as mild hemophilia. The pathogenesis is based on the fact that there is defective fibrin formation which impairs secondary hemostasis, causing deep tissue bleeding. Clinically, these patients will present with hemarthrosis in the joints and muscle hematomas, bleeding after trauma or surgery, and severe cases have risk of intracranial hemorrhage. Laboratory findings in these cases include a normal prothrombin time, normal bleeding time and a normal platelet count. We have a prolonged activated partial thromboplastin time and mixing studies generally corrects the APTT unless factor inhibitors are present. Complications of this disorders include development of inhibitors or antibodies to factor 8 or 9 and chronic joint arthropathy from recurrent bleeding. 1 Willebrand's disease is another inherited disorders of bleeding. First, let us see the role of 1 Willebrand factor. 1 Willebrand factor is a factor which mediates platelet adhesion via glycoprotein 1b. This acts as a carrier protein stabilizing factor 8. So, the deficiency of 1 Willebrand factor will not stabilize the factor 8 and will lead to severe bleeding in these patients. So, we can classify 1 Willebrand's disease into type 1, type 2 and type 3 disorders. Type 1 disorder, there is partial quantitative deficiency. It is an autosomal dominant disorder and is the most common type of 1 Willebrand's disease. Type 2 is associated with qualitative defects and type 3 there is severe quantitative deficiency in these cases. Clinically, these patients present with mucocutaneous bleeding, there is easy bruisability, there is epistaxis and patients may also present with menorrhagia. Prolonged bleeding after surgery or dental extraction is also a common factor which brings the disease to clinical attention in these patients. As far as the laboratory parameters are concerned, the patients will have normal platelet count, there is prolonged bleeding time and abnormal PFA test. There is reduced ristocetin cofactor activity confirming the 1 Willebrand factor dysfunction. There is also a mildly prolonged activated partial thromboplastin time due to factor 8 decrease. With this, we come to the end of this session. I hope you had an informative lecture. If you have any questions, please drop in the comment box. Thank you.